morning, everybody. We are here for Blood Management Awareness Week, and we have Dr. Dan Marco, who's a hematopathologist from Diagnostic Services of Manitoba, and he's going to do a talk today on uremia. So welcome, Dr. Marco.
Thank you.
Oh, can everybody hear? Can you just wave if you can hear us? You telehealth land there? Perfect. Oh, they did. Yeah, some of them did. There's some that there's over there.
All right, thank you. Today we are going to be talking about uremia.
Woo!
Not only uremia, but we're going to be talking about platelet dysfunction in uremia. There are many, many, many consequences of uremia, so we're just going to focus on the platelet. Before I start, I have to put this one up. I have no financial interest in this talk whatsoever. There's no conflict at all. So just so that we're all on the same page, thrombocytopathy is different than thrombocytopenia, where thrombocytopenia is a decrease in platelet count or a quantitative issue, where the thrombocytopathy is a qualitative or functional issue. There are many, many types of thrombocytopathies. The rare ones, I can just come up here and point. The rare ones are the hereditary ones, things like Glasman, Bernard-Cillier, Scott syndrome, and the list goes on and on and on and on. In fact, there's hundreds and hundreds of them. More commonly are the acquired causes of thrombocytopathy. These include drug-related, which is the most common of the thrombocytopathies, aspirin, Plavix, the list goes on. Myelodysplasia. Why myelodysplasia? Because the red cells, or the platelets, are actually all screwed up. Cardiac bypass, and today we'll talk and focus on uremia. So here's the objectives. We're going to define uremia, give you some clinical manifestations of uremia, extensively talk about normal platelet function, and your head will explode after that. It's a joke. It's a joke. Just trying to get the audience laughing, because you're going to be sleeping in 15 minutes. Then we will talk about the pathogenesis, the role of the uremic toxin, nitric oxide, and some treatment. So what on earth is uremia? Well, uremia is the clinical pathological manifestations of azotemia, which is the high levels of urea, which is equal to the high levels of nitrogen, which comes from ammonia. That is bad, so you want to get rid of that. I will figure out. The forward button is forward. I keep looking and say, oh. What is urea? How many people remember the Urea Cycle? Urea Cycle? Anyone? Last time I gave this talk, several people rose their hand and claimed that they knew it. But let's briefly go over it, just very briefly, so just bear with me. So you have really nasty ammonium, I should say. This is transformed to this carbonophosphate. Carbonophosphate will then interact with ornithine here to make citrulline. And then many, many steps later, actually one step later, you form arginine. Arginine will be converted back into ornithine via this arginase. And this arginase, one of the byproducts is urea. Isn't that clever? So it's not as bad as we remember in biochemistry, is it? The urea cycle. It's just a few steps. And it serves a very important purpose. However, if you have kidney dysfunction, guess what? You're not going to get rid of this urea. Clinical manifestations of urea, well, there is a whole host of clinical manifestations of urea. many different neurological, cardiovascular, skin. This is actually this uremic frost which occurs. Many hematological dysfunctions as a result of uremia, endocrine, and the list goes on and on. And we will be talking about each of these. I've expanded, but no, I'm just kidding. We're just going to focus on the platelet dysfunction. There's different pathological pathways for all of these things. So if you ask me, well, how does one get itching or something from uremia? I'm going to say I don't know, because I only know about the hematological consequences of uremia. The platelet disorders, in the broad sense of bleeding, there are coagulation-type bleeds and platelet-type bleeds. The platelet-type bleeds usually happen immediately following trauma and are usually mucosal surfaces in skin, versus coagulation-type bleeding, which is usually delayed following trauma, usually is in the deeper joints and soft tissue. This is like hemophilia. The majority of dysfunctional would be platelet-type bleeding. So the most common bleeds in uremia is no bleed. No bleed. This WHO grade 0. It's actually the most common. If you were to have a bleed, it would be a very small, so-called WHO grade 1 bleed. Very, very minor. For the higher grades, 3 and 4, you essentially need some pronounced injury and or surgery. Now the degree of azotenia, or the degree of urea, has nothing to do with the bleeding risk. And keep that in mind, because we'll talk about how urea has nothing to do with the direct dysfunction of the platelets. So they do not, urea does not directly cause dysfunction in the platelets. Lab manifestations, in vitro coagulation tests are normal. You may or may not have thrombocytopenia. If you have a dysfunctional platelet, guess what is going to happen? Well, it's not going to do its job, and so it's going to be cleared by the spleen. Platelet dysfunction tests are usually abnormal. But I should say that there's not a distinct pattern with the platelet dysfunction abnormalities. The normal platelet function. First, you have some endothelial injury exposing collagen, and under high shear forces, what will happen is von factor will bind to the collagen and then bind to the platelet, the 1B95 complex on the platelets. Under low shear forces, when the blood is somewhat stagnant and not moving that much, the platelets bind directly to the collagen with the 1A, 2A glycoprotein on the surface of the platelet. So that's the first step, platelet adhesion due to some endothelial compromise. Then we get to this slide, and everyone gets upset because this is a very complicated slide, and I'm going to go through all of this just to make the audience crazy.
Yay.
You guys are killing me. You need to loosen up. All right. So this is now, we did adhesion. Now we are going through platelet activation. So platelet activation is 5 steps, 5 things, 5 big events happen. The one that is most pronounced, the one that we see under the microscope, is the change in the shape. You get little hair-like projections in an activated platelet. Other things that happen are the degranulation of your alpha, followed by your dense granules. Then what happens is you can activate the arachidonic pathway, which produces thromboxane A2, which then activates the platelet further. We'll get to that in a little bit. Another thing is you will activate the 2B, 3A, glycoprotein, and cause aggregation. And finally, you will activate the scramblase, which will lead to the binding of zymogen or vitamin K dependent clotting factors. And all we'll talk about, don't worry, we'll talk about each step. So what happens is some molecules, the most powerful being thrombin and thromboxane, will bind to these G proteins, which will then activate this phospholipase C. Phospholipase C will then split this PIP2 phosphatidylinositol bisphosphate into diacetylglycerol here and inositol triphosphate. Who can say those several times quickly? Anyone? In the back? Natalie? No? Okay, anyhow, diacetylglycerol will then activate, and this is a simple, this is the, there's a lot of steps in between, but this is the broad picture. Diacetylglycerol will activate this protein kinase C. And the protein kinase C will do several things. It will activate this glycoprotein 2B, 3A, but it will also phosphorylate this platelet leukocyte string protein, or pelstrin. This is an important protein which aids in the degranulation of your dense and alpha granules. So you need all this to happen to activate. Cyclic AMP actually is a brake. Puts the brakes on the protein kinase C and it stops. Keep that in mind when we talk about nitric oxide. So just put that somewhere in the vault of your head. IP3 will also produce an inositol triphosphate. Inositol triphosphate is sort of like a key to a door. And guess what the door has on the other side? Yes, that's right. That's right. Calcium. So IP3 will open up the door, flood in calcium, and then calcium will do a whole bunch of things. And the consequence of the influx of calcium, these little canicular channels, the first thing that happens is the myosin gets activated, and this causes the change in shape, but it also aids in the degranulation of the platelet. You also have the calcium activating the phospholipase A2, which turns on the arachidonic pathway, which causes thromboxane A2. Guess what will happen with thromboxane A2? Yes, it will not only help in the degranulation, but it will then activate more platelets. So you have an amplification of activation when you first start this whole cascade from taking place. Another thing that we'll do, it will aid in the activation of scramblase. We'll talk about scramblase because everyone's curious about what the scramblase is a little later. Everyone understands? Yes? Oh, very good. You guys are a very smart audience. Quiet. You don't laugh at my jokes. I've told several jokes and everyone has ignored them.
Okay.
Anyhow, this is the platelet. This is a real picture of the platelet. Here you have these little canicular areas which hold the calcium. You have the alpha granules and your dense granules. The alpha granules actually aid in coagulation. So you have factor V on Willebron, so it aids in the micro coagulation. or clotting. The dense granules essentially influence the environment around the platelets, so you have things like serotonin, histamine, which causes vasodilation, epinephrine, and ADP will actually activate more platelets. Finally, so we've had platelet adhesion, followed by platelet activation, followed by platelet aggregation. So this is when platelets all clump together and form a nice solid clot. Urea, as I alluded to earlier, will cause nothing. It will indirectly cause platelet dysfunction and indirectly inhibit platelet activation. Pathogenesis. So as a consequence of increased uremia, the urea cycle just gives up. So you don't have the nice cycle, but you still have ammonia being built up. So you have to get rid of that. So there are alternate pathways that arginine can take to get rid of it. And unfortunately, some of those consequences are bad because you can produce these uremic toxins. Uremic toxins can cause abnormal platelet adhesion and aggregation, also disrupts the scramblase activity. You also have a role in nitric oxide, which also causes a defect in scramblase and causes a whole host of platelet activation issues. Also, as a consequence of uremia and the byproducts of uremia, one can cause anemia due to erythropoietin deficiency. We'll talk about that in a bit. The uremic toxins. What are these mysterious uremic toxins? Everyone's curious?
Tell us.
Oh, that was very forceful. Okay. So let me try to pronounce these without stuttering, but I often end up stuttering and everyone laughs at me. The guanidine succinic acid and methyl guanidine are the suggestive toxins that are produced. Okay, I've said it once. I said those once. I'm not going to say it again, unless you want me to. Really? Guanidine succinic acid and methyl guanidine. What are these? Well, here's the urea cycle. Remember that urea cycle? Well, here's arginine. And arginine has this arginase back to ornithine. But when there's a buildup of urea, because this is eliminated in the kidneys, guess what happens? This somehow causes negative influence on the arginase, and now you have a backlog of arginine, and it has to go somewhere. So one of the pathways is this pathway producing guanidinosuccinic acid. The other pathway is this pathway here, producing the methyl guanidine. So these are just alternate pathways to get rid of the nasty ammonia. And urea is just the bystander. Or is it? Or is it? Because if you don't have the increased urea, urea won't influence the arginase. And then none of this will happen. So as a consequence of these uremic toxins, you will have dysfunction in all or and none of these glycoproteins. These are glycoproteins. These are little sticky things involved in adhesion and aggregation. So you may or may not cause dysfunction in any one of these. And these are, here's the toxins floating along. Here's a platelet. So if the toxins only affect this side, maybe only a few of these are affected, where the other side of the platelet can be just fine. So you have not full dysfunction. Now, if there's so much toxins that the entire platelet's out of commission, then you have true significant dysfunction. So it's really what's happening in the microenvironment that really matters. as a consequence of messing up these glycoproteins, you're going to mess up platelet adhesion, you're going to mess up aggregation, and you're going to mess up scramblase. Scramblase. Actually just like saying scramblase, so that's why I just repeat it over and over, just to amuse myself. Anyhow, this mysterious scramblase, here it is. Here's the surface of the platelet. All right? In normal steady state, what happens is the choline, or the sphingolipids, the choline phospholipids are kept on the outside via this enzyme called flopase. Flopase. Do you think I'm making this up? Oh, sure.
Yeah.
I am making it up. I'm just... No, it's really called a flopase. Flopase for out. So you have, they're kept on the outside via this flopase. Can anyone guess what keeps the aminophospholipid, so phosphatidylserine and phosphatidylmethitol, on the inner surface? Anyone? Flippase, yes. Very clever. So you have flippase, which flips these on the inside. The flopase will flip these on the outside. Now, when the cell is stressed, or there's some death domain which causes apoptosis, or some oxidative effect, this enzyme called scramblase will then scramble things up. Isn't it clever? So what will happen is, what should be on the inside in normal steady state is now placed on the outside. And what is on the outside is now placed on the inside. So you essentially inhibit the flopase and flippase. Make sense? So why is this important? Who cares, you say? People are saying, yes, no one cares. Because without this, without platelet activation, you don't have this. So on the surface of the platelet, you have phospholipid interacting with the vitamin K-dependent clotting factors, 2, 7, 9, 10, for the cascade to occur on the surface of the platelet. And so if you have uremic toxins, which will interfere with the scramblase, decrease the scramblase, you don't have the phospholipids on the outside, especially this PF3 or phosphatidylserine, and guess what's going to happen to this? Well, it's not going to take place. So your clotting cascade is in vivo stopped, because it's not going to work. At least on the platelets. Now, funny, the scramblase is actually in every cell, and in the red cell, the same consequences. You have flippase, flopase, but this just illustrates that the clotting cascade not only happens on the surface of the platelet, but actually can happen on the surface of the red cell as well. So the red cells play a very vital role in clotting as well as platelets. So everything is connected. Isn't that just fascinating? Isn't that fascinating?
It's magical.
Okay, nitric oxide. Nitric oxide plays many, many roles. Vasodilator, reduces platelet adhesion, is involved in the oxidative burst in neutrophils and macrophages. So here again is that one picture, the Urea Cycle. Everyone's familiar with it by now. Here's what happens when you plug up this step. Here's urea, here's the arginase. You block this step here. What will happen is, again, the arginine needs to go somewhere. what happens here is the arginine can go to citrulline. Okay, very, very interesting. So, when it goes from arginine to citrulline, this is done by nitric oxide synthase, which guess what it produces? Yes! Isn't that clever? Nitric oxide. Okay, so what you're saying again? Nitric oxide leads to an increase production of GMP. This increase in GMP, several steps later, will turn on this inositol triphosphate receptor-associated protein, or glycoprotein, which will, guess what? Turn off inositol triphosphate, which as a consequence will stop the calcium from flooding in. You should hand to the audience. Don't just you really should.
We are awake.
Your faces. So, what happens as a consequence of that cyclic AMP is the cyclic AMP will inhibit this phosphodiesterase. Phosphodiesterase, this is interesting. Remember I told you cyclic AMP inhibits protein kinase C? Well, under normal circumstances, cyclic AMP is broken down to AMP and has no function at this point in the activation of the platelet. If you inhibit the phosphatidylserine, you're going to not break it down, therefore increase the cyclic AMP, therefore increase the inhibition of protein kinase C. If you stop protein kinase C, guess what's going to happen to pelstrin? You're not going to phosphorylate it. And as a consequence, look at what happens. Everything turns off. It's like you've turned off this step, you've turned off this step, you've turned off this step. Everything where the red line is inhibited. So you essentially take home message, your platelet activation is halted. Now this anemia. What does anemia have to do with any of this? So, the uremic toxins also will interfere with the oxygen sensor model, which leads to the production of erythropoietin, which is a growth factor and a hormone, which causes the proliferation and differentiation of the erythroid series. So what happens in hypoxic situations is these HIFs, or hypoxic inducible factors. You have an alpha factor and a beta factor. They link up together, and they're transcription factors. And so what they do is aid in the transcription of erythropoietin genes. Uremic toxins will actually interfere with the beta and the alpha coming together, and guess what will happen? You will stop. You will stop, or lead to the diminished production of erythropoietin. As a consequence, one can get anemia. So it's not only the platelets that are messed up, but it's the production of red cells. And if you have anemia, you will cause more platelet dysfunctions. Okay. This represents a blood vessel. Isn't that nice? I did not draw it myself. So here's a blood vessel. Here's the middle of the blood vessel. You are rushing all the red cells down, and as a consequence, all the platelets are moved to the edges. The edges represent endothelium. So if you can imagine, if you have a tear here in your endothelium, you don't want the platelets in the middle, you want the platelets out here. In order for that to happen, you must maintain a nice or adequate hematocrit to push the platelets toward the side and give them a fighting chance. But if you're anemic, guess what will happen? These won't be near the side, and the platelets will just float off and ignore where they're needed. Make sense? So, one of the treatments for platelet dysfunction in uremia is, yes, give red cells. Give red cells. So here's a uremic patient who's actively bleeding. The quickest thing you could do is raise the hemoglobin level above 100, give some desmopressin. Cryo is way at the bottom of the list, way at the bottom of the list. For chronic and for acute, you could do dialysis. Long-term estrogens, sort of controversial, and dialysis. So here's the roadmap of how to treat. So the desmopressin will cause a release in factor 8 and von Willebrand, and may actually enhance glycoprotein expression. Well, that's good because remember the uremic toxins will cause the glycoproteins to be all screwed up. So if you can give them a nice chance of survival, that's good. Unfortunately, it doesn't last that long. Correction of anemia is probably the most important thing for acute situations. Chronically, you can consider the ESAs, but those are a little messy and they take weeks to kick in. But the good thing about the erythropoietic stimulating agents is that it can also enhance the glycoproteins, enhance this G protein, and enhance the influx of calcium as well. Conjugated estrogens, very controversial. It has to do with increasing the influx of calcium. So calcium, again, is very important to all of the steps in the, or most of the steps on this side of the equation in platelet activation. You can use this for females, but obviously you can't use it for males. There's no data to suggest that it would be effective in males. Cryo at the very bottom of the list. The role of platelets. The role of platelets. What is the role of platelets? I just told you that the treatment is red cells. Red cells. But then you're thinking, oh, this is a platelet problem, so why not just give some platelets? Logical, yeah? Everyone's nodding or saying no. It's not logical. Anyhow, here's the role of platelets. Yes. Now, it won't hurt.